Hello, everyone. Welcome to the Cardiogenic Shock Virtual Grand Rounds. My name is Shana Costello. I'm the National Director of Clinical Studies and Novel Registries here at the American Heart Association. We are so thrilled to have you all with us today. If you can go to the next slide, Lauren. Before we jump into today's content, just want to cover a couple housekeeping items with all of you. Today being recorded. Attendees will receive a copy of the recording. It will also be uploaded to our website. All of you are muted as participants today, so please feel free to submit any questions that you have for our speaker and panelists into the chat at any time throughout the webinar today. And Lauren, if you go to the next slide. Just a real quick disclaimer that the recommendations and opinions presented by our guest speakers may not represent the official position of the American Heart Association. The materials are for educational purposes only and do not constitute an endorsement or instruction by the Heart Association. The American Heart Association does not endorse any product or device. Next slide. So with that, I'm going to hand it off to Dr. Morrow. He is our co-chair for the Cardiogenic Shock Initiative and a critical care cardiologist at Brigham and Women's Hospital. So Dr. Morrow, the floor is yours.
Great. No, thank you so much, Shana. Thank you to all of our audience for joining this HA Cardiogenic Shock Quarterly Grand Rounds. We've been looking to bring in topics that are important to all of us who take care of patients with cardiogenic shock in various systems of care. We are very fortunate today to have an outstanding speaker and then panelists to address the use of VA ECMO in patients with cardiogenic shock, which has been a evolving field and very mixed data. So it will be very important for us to talk about appropriate selection of patients and really review the data together. And no one better to kick us off with that than Jason Bartos, who's a leader in this field from one of the cutting-edge centers for use of ECMO in patients with cardiogenic shock at University of Minnesota. And so it's my great pleasure to hand things over to Dr. Bartos.
Thank you so much, and thanks for having me today. Thank you all for joining as well to talk about this topic, which is certainly near and dear to my hearts and many hearts. I think the panel is going to be a really fun and amazing discussion. So my goal with this didactic portion is to sort of set some foundations and to give a sense to narrow the discussion of ECMO, in particular to the VA ECMO that we would be using for cardiogenic shock. So we'll talk about those things and give some background, and then look very much forward to the discussion that we're going to have next. So disclosures, I have some federal funding, and the Helmsley Charitable Trust supports our local ECPR program, so some funding from them as well. So ECMO really is just the use of a oxygenator that provides oxygen and ventilation with a pump connected to the patient through cannulas. And it can be connected in a variety of ways, but in general, when we're talking about cardiogenic shock or cardiac arrest, which is a part of cardiogenic shock, then we're talking about VA ECMO. And this is a picture in the upper right of a VA ECMO circuit connected to a patient in their groin. This patient's head is on the left, their feet is on the right. The red cannula there is in the femoral artery. The more purplish cannula is in the femoral vein, removing the blood from the patient. And importantly, and we'll talk about this undoubtedly as we go forward, this distal perfusion catheter, which is perfusing the leg, taking a little bit of blood off of the arterial cannula. So that's the typical peripheral VA ECMO setup. There are many different devices that can support ECMO, and this is a device that we use from McKay, the CardioHelp device, but there are an assortment of different devices that provide the pump and the docking for the oxygenator, so you can provide that support to the patient. Again, there are different types of ECMO. In general, we talk about VA ECMO, but the term ECMO gets used kind of generally, so I want to make sure that you know the differences in the different types. So VV ECMO is for lung support. You're pulling blood from a vein, putting it back in a vein. That's not what we're talking about today. VA ECMO is pulling from a vein, putting it back in a central artery. This can be connected in a variety of different ways, whether it be peripheral in the groin, peripheral in the axillary artery, or central ECMO through into the right atrium or the cava through a sternotomy and then back into the aorta. There's also a type of ECMO that is growing in use, VPA ECMO, that some people start to lump into the VV or VA, depending on how you think about it. But I think it is its own entity. If you had cardiogenic shock specific from the right ventricle, you may actually choose VPA ECMO for that support. It does support the right ventricle and gives you oxygenation and ventilation support. And then there's LAVA ECMO, or LA to VA ECMO, where you have your venous cannula across the atrial septum into the left atrium, pulling blood directly from the left atrium as well as from the right atrium and IVC, and then putting it back into a central artery. And so all of these are under the umbrella of ECMO, but in general and in clinical trial use so far, VA ECMO has been the device that is used through the peripheral means for the support of the patients. The cannulation process this is our example of how we cannulate and some times associated with that. I just want to give you a sense of what you could reasonably achieve when cannulating for VA ECMO. Of course, there is expertise involved. So if this was your first case, the times in particular would likely be very different. But I think the general approach is still true. The goal is to do it as quickly as possible, but as safely as possible. And these are large cannulas. As you can see actually in the bottom left, this is a scale picture of a 17 French cannula that you might use for the arterial cannula and a 25 French cannula you might use for a venous cannula, as compared to the best ultrasound of artery and vein and the femoral artery and vein that you might have. This is actually from a patient coming in for a coronary angiogram. So they have not been getting CPR for 30 or 45 minutes. They have not been getting repeated doses of pressors, and they don't have horrible coronary calcification of the vessel. So this is sort of a best case scenario, and still you can see the 17 French in the scale representation here is about the size of that femoral artery. So you don't have a lot of wiggle room, and these large cannulas can certainly cause problems. But the goal is, again, to do it safely but quickly. Our goal when we're cannulating patients who are having ongoing cardiac arrest is about 4 to 5 minutes from needle to ECMO start. And that is fast as people compare times for ECMO, but it is achievable using a process of ultrasound guidance and fluoroscopy for confirmation. And we'll talk about this in the clinical trial setting. Using a fluoroscopy in the cath lab is not an unreasonable request for these. Certainly you can cannulate in an assortment of settings, but having that fluoroscopy guidance does help with the speed and the safety. The most common complication of VA ECMO cannulation is vascular access complications, both ischemia in the limb where you're cannulating, and then again, if you're doing peripheral VA ECMO in the groin, that'll be the leg, or bleeding complications from that site. If you are undergoing CPR at the time, keep in mind, and this is probably not a point that you need convincing on given who you are, but the use of ultrasound, I would say, is mandatory for this. There is some disagreement in that respect across the world, but I would argue for ultrasound, and this is the reason why. If somebody's getting CPR, their artery and vein are both often pulsatile, so feeling a pulse doesn't necessarily guarantee you're feeling the artery, and the blood can be hypoxic and blue in both vessels. So the cheats we might use to determine whether we're in an artery or vein are not as applicable when you're undergoing CPR or when you're very sick. And certainly when you have a higher risk endeavor like putting in these large cannulas, you need to be certain. So ultrasound, I would argue, is mandatory. Fluoroscopy is helpful, and I consider a big plus. The cannulation, or where the cannulas land, is shown here on the CT scan. This is the same patient, but two slices because they're slightly out of plane. The arterial cannula from the groin usually lands in the distal aorta or in the proximal iliac artery. So it is true that all of the blood through this peripheral VA ECMO is going retrograde up to the coronaries and everything in between. And then the venous cannula, again, starting in the groin, goes all the way up to the heart. And when you have fluoroscopy, you can actually place the distal part of this venous cannula up into the SVC. And this allows near complete drainage of the SVC, IVC, and the right atrium simultaneously with that venous cannula, and helps you unload the heart very effectively mimicking cardiopulmonary bypass for bypass surgery with near complete removal of that blood flow. And of course, when we're talking about cardiogenic shock, we can't not think about the various stages and parts on the spectrum of cardiogenic shock. Importantly, when we're talking about ECMO, we're not talking about the other parts below D. In general, we're aiming for D and E stage cardiogenic shock. Now, you'll see in at least one of the trials, there were some patients with stage C included, but the target is stage D and E. And so these are the people who are rapidly deteriorating despite some treatment for their cardiogenic shock, or they are in extremis and undergoing active resuscitation with CPR or boluses of inotropes and pressors. And so this is the patient population that generally we're looking at for this use. Now, VA ECMO can be used more broadly than this as well, but I do just want to give you some sense of the various uses. So cardiogenic shock is the biggest one and encompasses all the different causes of cardiogenic shock, not just the acute MI population, although that's the most studied population. It can be used for the other different etiologies of cardiogenic shock as well. I add septic shock because we talk about septic cardiomyopathy. And while we think of them as septic shock patients, they do have at least an inability to augment their cardiac output, if not the addition of cardiogenic shock as well. And so that's a classic use. Septic cardiomyopathy is a classic use of VA ECMO. But some people are moving into using it for septic shock alone, without the cardiogenic component, with some slightly different management techniques to be able to add the 5 liters of flow from ECMO to the already augmented cardiac output that a patient may have in septic shock. So there may be a future more standard use in that setting, but right now, if you are treating somebody with pure septic shock without a cardiac component, that is outside the typical uses. And then massive PE is also a high-risk hemodynamically significant PE would be a current use, very good use for VA ECMO in many hands as well, because it is readily addressed and reversed if you can deal with the PE. So that's a growing use as well. There are very few absolute contraindications to VA ECMO use. The first is unrecoverable organ injury, and so that would be the heart. If you don't have an option for transplant or VAD, if you have very poor heart function, that would be an absolute contraindication, or a devastating neurologic injury. I use that with a lot of caution because neurologic injury, especially in the setting of cardiac arrest, brings a lot of opinions early on. And in general, in the world of cardiac arrest in particular, neuroprognostication is not easy. And so what some people would call a severe neurologic injury turns out, if you wait long enough and support them, will be recoverable. And so we have to be very careful when we apply an unrecoverable organ injury without very clear concrete data about it truly being unrecoverable. And then severe aortic insufficiency is one that is also very difficult to treat, and in general has been very challenging with VA ECMO because the severe AI will just allow the left ventricle to flood and cause horrendous pulmonary edema. But there are some people that are publishing growing use of LAVA ECMO in particular for this indication, and so perhaps we will see that we can use that specific subset of ECMO for people with severe AI. Or other innovations may come down the line. But if you are not able to do those types of ECMO or have another way that is not yet published, which I look forward to hearing about, in general, severe AI is considered a contraindication to VA ECMO. Not necessarily mild or moderate, but truly severe AI. Relative contraindications are vast. There are many, and different centers will use different relative contraindications, and that's okay with different experiences. So chronic organ dysfunction of various types may be a relative contraindication. Prolonged CPR and how we define that is changing all the time as we have patients with routinely 50 or 60 minutes of CPR that do very well. But certainly we have a few patients that have gone out even to 98 minutes of CPR that still survive. So what does prolonged really mean? But it is a relative contraindication for certain. And as part of your ECMO program, you likely have some brackets around who you would consider a candidate. Uncontrolled bleeding or anticoagulation contraindication, in particular brain bleeds, and then adding ECMO is a relative contraindication. There are people that have published and are using ECMO, including VA ECMO, for trauma and for actually reduce venous bleeding. And then also for cardiac bleeding in a post-cardiotomy state, using ECMO very intentionally to reduce transpulmonary blood flow and reduce bleeding from a cardiotomy site. So there are, again, it's a relative contraindication. It's something to be thoughtful about, something to consider whether ECMO could be harmful or helpful. And also many people now are starting ECMO without anticoagulation at all in high-risk patients. So Even if you can't get anticoagulation or can't give anticoagulation in a setting, it doesn't mean you couldn't necessarily put in the ECMO. But again, something to be thought of carefully. Aortic dissection is another one that historically was in the absolute contraindication category, and then we learned more and more that we can actually use it for certain patient populations. There are lots of worries around aortic dissections and adding ECMO cannulas and adding retrograde flow. So this just needs to be done very carefully if it's going to be done at all, but historically has been a contraindication. And then the other thing in relation to PE is that lytics and the use of lytics for a PE as they're heading to you for ECMO are not an absolute contraindication. And you can still cannulate very effectively and safely even after lytics have been given. Remember, you are making large holes in the artery and vein, but you are leaving them plugged with your cannulas. So there are still, you can still use ECMO safely in that case. And in general, mortality, as at the very sort of best end, we're thinking about 50% mortality when we're adding ECMO. So when you're talking to patient families, that's sort of the level that you're at or worse in general when you're thinking about ECMO. There are a slew of hemodynamic support devices for cardiogenic shock, as many of you know. And ECMO is in this ecosystem, but it is not the only member of this population. And so it is important to just remember that you are thinking about ECMO, but you're also thinking about the other tools. And if there one is a tool that will be better used for that specific patient, you're obviously going to go with that one. But that does also lend itself to some issues and differences when you're using clinical data or clinical trial data for these different devices, because they tend to be kind of absolute and it's hard to do patient by patient selection in a clinical trial setting. So you want to really phenotype your patient. What part of the heart is failing? Is this cardiogenic shock alone? Is it a mixed shock? Either hemorrhagic, vasoplegic, all the different types, obstructive shock. You want to have a sense of what you're dealing with and what tools would be useful. The trajectory of that patient, are they getting better or getting worse, will determine which tool and whether ECMO is useful. The likelihood of a rapid recovery or time to deterioration and what has already happened for this patient, how many other organs have been affected, will also determine your use of ECMO. There's some patient-specific risks. Anatomy, peripheral vasculature anatomy would be the most obvious, but some of the adult congenital patients can be pretty tricky to cannulate, so you want to think about that. Disease processes and goals of care of those patients in particular. And then center-specific risks, your case volume. If you do 10 ECMO patients a year, the likelihood that you're going to want to take on a high-risk sort of abnormal case might be pretty low. So you just, as you're thinking about using these things, think about your overall institutional risk profile, the expertise and resources that you have available to you. Now, the clinical protocols, this is not a randomized trial, but this is a prospective trial using a protocol that I think is pretty typical to many centers that have ECMO today. So I show it for that in that context. So if you think about your patients with cardiogenic shock from various causes, if they are critically ill and deteriorating, or if they have poor oxygenation in general, the centers will go to VA ECMO. VA ECMO is the device that provides you oxygenation support as well as the hemodynamic support. But if they're also deteriorating rapidly and extremely sick, you might go to VA ECMO directly because of the risk of a failed bailout of the other strategy. But if they're not in one of those two categories, then often centers will start with other devices and try to stabilize and even reverse their pathology with another hemodynamic support device. And then if that fails, or if they develop oxygenation issues, then move on to VA ECMO. It makes sense. It's a pretty straightforward path and idea in terms of an escalation pathway to ECMO. The issue and the thing you want to consider is the time that it takes for each of these steps. And this is going to be unique to your individual center. So if you know, or you will know, what the time is that is sort of required to gear up your system to get somebody on ECMO in the first place, or to get them on the first device if you've chosen a non-ECMO pathway for that. Then how much time do you want to give the patient in between in order to demonstrate that they're succeeding or failing with that initial strategy? And then if you're going to transition them to ECMO, the time it takes to gear up and get them cannulated for that. I mentioned the 4 to 5 minute time, sort of needle stick to ECMO time, but for many centers, the time before the needle stick is much, much longer. And so you want to consider all of those things for an individual patient, because each of those time delays will likely add up to injury if the patient continues to worsen. And so that's built into this sort of strategy. This prospective study from Columbia had 51 patients, which they had this, again, the protocolized approach to be VA ECMO first or VAD first. They then looked at the outcomes. And I think importantly, the 65% of the patients who got an Impella first still went on to VA ECMO. Their system worked. They escalated as they needed to, and they got them on VA ECMO. 33% of these patients were post-cardiac arrest, so they were a relatively sick population with a lactate around 5 and a mean pH of 7.3, and they had a survival around 50% for both limbs. No difference, but they had an escalation pathway that minimized use of ECMO in the population that went to the Impella first. We do have 2 randomized controlled trials that have looked at use of ECMO in cardiogenic shock, and so I'll talk about those briefly as well. First, the ECMO CS trial here from Ostadal et al. 1-to-1 randomization between immediate VA ECMO versus conservative therapy. Conservative therapy allowed for transition and crossover to ECMO if needed, but they didn't necessarily have immediate VA ECMO. This was in the Czech Republic with Jan Belovik's group, who's done a lot of ECPR ECMO work as well. They had 117 patients in this with a mix of different causes of cardiogenic shock. This wasn't just MI. Their lactate on average is around 5 for this study. You can see their systolic blood pressure below 85 on the median. The therapies that they were getting at randomization included balloon pumps, ventilation, and renal replacement therapy in a good portion of the patients, at least for the mechanical ventilation. And the causes are shown here with, again, half the people having STEMI, but a significant number of people in other causes of cardiogenic shock. This is the criteria they applied, really focusing in on stage D and E. Again, the rapidly deteriorating form of cardiogenic shock or extremis with boluses of pressor or undergoing active cardiac arrest. These were their endpoints. They had a composite primary endpoint of death, implantation of another circulatory support device, or resuscitated cardiac arrest, and then they broke them out to death specifically or another mechanical circulatory support device. You can see the composite endpoint. All of them were similar between the 2 groups, except for another mechanical circulatory support device. But the composite outcome was similar between the 2 groups, and the death rate was also similar. And those 2 things are shown here in graphs below. Importantly, 39% of the patients in the conservative group went on to get VA ECMO, and on average, or the mean was 1.9 days after enrollment. So it wasn't a long time after, but it also wasn't immediately. They sort of had this 2-day delay in getting those folks from the conservative group the VA ECMO. But again, the outcomes similar between the 2 groups. The second study, randomized control trial that we have is the ECLS shock trial. This had 420 patients randomized between group 1, which included the ECMO plus treatment of their MI. In this population, they all started with an acute MI and cardiogenic shock from that MI. So they were all planned to get revascularization either by PCI or by CABG, theoretically. Most of them were PCI. And they, again, group 1 had ECMO, group 2 did not, but they could cross over. The inclusion criteria are shown here. This is not as strictly stage D and stage E. There were a significant number of stage C shock patients in this trial, but they all, again, started with an MI. They had the sort of the classical cardiogenic shock MI qualification of the systolic blood pressure less than 90 for 30 minutes or the need for inotrope compressor. They required a lactate above 3 and that planned early revascularization, again, mostly by PCI, but also allowed by CABG. And then 1 sign of organ impairment needed to be present. They excluded people who were resuscitated for more than 45 minutes from CPR or having CPR for more than 45 minutes. A mechanical cause of the cardiogenic shock, onset of shock more than 12 hours before, or severe PAD because they wouldn't be able to place the ECMO. They had an age range, pretty broad, with age 18 to 80. And other causes of shock were excluded as well, pregnant patients in addition. They could use other hemodynamic support devices, and I will show you that. They had some criteria for those as well. So these are the baseline criteria for the ECLS shock trial. The age, predominantly male sex shown there. Importantly, lots of signs of impaired organ perfusion. They required 1, but the vast majority of patients had all 3. And so these are shock patients clinically as well as by the numbers. Systolic blood pressure in the median was 95, and they had the range shown here. The STEMI population, again, all of them were MIs, but 66 or 2/3 of the patients in both arms had STEMI. CPR prior to randomization in the majority, so 78% in both arms were post-arrest patients. And this is an important characteristic of all cardiac arrest trials, or all cardiogenic shock trials. And there's a huge predominance of cardiac arrest patients in those trials. And this is a big factor for the outcomes when you may have end-stage brain injury from the cardiac arrest underlying those outcomes. It's not just a failure of management of the cardiogenic shock. And in this case, it's again 78% had cardiac arrest. The duration of the longest CPR was 20 minutes, but they may have had multiple episodes of CPR. And again, they were excluded if it was over 45 minutes, but they can have a lot of CPR and still be in this trial. Many of them, it's sort of evenly split between 1, 2, and 3 vessel disease causing their MIs. So predominantly some substantial coronary illness. The shock severity is shown here, EF 30%, so not so horrible. pH is around 7.2, lactates around 7 in both groups. And the SCAI, this is the most important part, is the SCAI stage. About half of the patients were stage C in this trial, so not as sick as the other trial, but they still had quite a few patients in D and E. And it's kind of amazing given how many people had cardiac arrest that some of those people post-arrest were still in stage C. So good resuscitation from the teams. This is the treatments they received. So PCI, again, in the majority, CABG was allowed. The ECLS therapy, of course, in the ECLS arm, most of them, the vast majority of them received ECMO, but only 192. It wasn't all 209. Some people died before they got on ECMO. And so 192 was actually the denominator for the patients receiving ECMO in that arm. 26 patients still received ECMO in the control arm as well. I mentioned that was allowed to cross over, just not the immediate randomization. However, 22 of them were in the within 24 hours. So the crossover did happen for the majority of the people that got ECMO in the control arm pretty early in their process. For most of them, actually still in the cath lab that they crossed over, but a few of them later. The duration of ECPR, of ECLS, about 2.7 days. So this is a little bit short for what I would expect. And it's interesting when you think about the cardiogenic shock patient and what they would require. Maybe this is because many of them recovered their EFs faster, and with an EF of 30%, they stabilized their shock. But I worry a little bit about what this means for the people who died. Were they withdrawn? Was care withdrawn early on in the process without giving them a full chance to recover? Again, I have a predisposition because I do a lot of cardiac arrest work, but still that's a huge problem for patients post-arrest, and 2.7 days of therapy seems a little early. The outcomes for ECLS shock are shown here. There was no difference between the ECLS group and the control group. And importantly, you can see the CPC score, the cerebral performance category, is sort of a crude assessment of neurologic function. CPC1 is completely normal. CPC2, you probably wouldn't notice much in talking to them. CPC3 and 4 is generally considered a poor neurologic outcome, and CPC5 is death. So you can see of the survivors, when they assessed at day 30, these were their CPC scores. So over half were normal, and then a smattering of the other groups. Importantly, though, when you look at the causes of death, and for those of you doing clinical trials, I strongly encourage that you include cause of death data in your analysis. It is so helpful to understanding the trial, and they did. This group did a great job of including that. The thing that's a little bit strange to me is that, again, the most prominent cause of death, over half of patients died of refractory cardiogenic shock, even in the ECMO arm. And so it's hard to interpret what refractory cardiogenic shock is doing when you're on full support from ECMO and how that's causing your death. The other important one to note is brain injury. Again, with the post-arrest population, a big problem, and those patients weren't going to do better no matter what you did with ECMO or other devices. So it is a power problem in these studies as well. Safety outcomes are shown here. ECMO, of course, comes with ischemic and bleeding issues, and that's not surprising. I want to just point out that if you include cardiac arrest in the world of cardiogenic shock, which I know for many groups is not a thing, but for us, we certainly do. And ECPR is a growing indication for ECMO. There are 3 trials that have been using ECMO for cardiac arrest, for ongoing refractory CPR, ongoing cardiac arrest. And that's called ECPR, that specific use of ECMO. And the arrest trial was one we did in the Twin Cities, which was the first one showing a great benefit of ECPR, but it was a small study because it was stopped early due to that benefit. So our ECPR arm had 43% survival compared to 7%. There have been 2 trials since. Both of them have been neutral trials. We can definitely discuss this in the panel if we want, but there are lots of reasons that may be that those are more neutral studies. But I just want to touch on this because as much as it's not cardiogenic shock in the form that many people would use ECMO to treat cardiogenic shock, it is still stage E, and I would say is a growing use of ECMO. There are some guidelines I just want to touch on, and then I will be done here momentarily. The 2023 AHA focused update for cardiac arrest guidelines did increase or bump use of ECMO to a 2A recommendation in the setting of ECPR for select patients in a well-equipped system of care to use ECMO for ongoing cardiac arrest. And of course, calling out that more data was needed on patient selection and who those selected patients should be. Toxicology has gotten a lot of recent play for VA ECMO as well. Toxicology is actually, or toxicological emergencies are a great use of VA ECMO because it's rapidly reversible. They metabolize their toxic medication, especially the calcium channel blockers, beta blockers, those sorts of overdoses are wonderful because they're so readily reversible. They just need to be supported in a very full way until they are able to metabolize those meds. So that's a 2A recommendation for use of VA ECMO in poisonings and overdoses related to those medications. MCS for cardiac arrest, as you may know, has been a little bit more difficult because of the mixed data in the clinical trials. And the things we really focus a lot on in class 1 and class 3, but I think the things that we just need to know for this in particular is, for as much as I talk about VA ECMO for cardiac arrest having that 2A recommendation, the same group of people for emergency cardiovascular guidelines said in 2025 a class 3 no benefit guideline for adult patients with cardiogenic shock after cardiac arrest and ROSC. So these people achieve ROSC, they have cardiogenic shock, and should not be using temporary MCS of any sort routinely. And here, like in many recommendations, the word routinely is doing a lot of work. So selected patients may still be fine, and that's what this 2B here is all about. But the routine use, every patient with cardiogenic shock getting mechanical circulatory support, they said was a class 3 no benefit. In addition, ECPR system of care work it grew in 2025. It went beyond just the 2A for ECPR, but really multiple recommendations related to the system of care, regionalization of care, and those sorts of things. So for more details on this, refer to these guideline documents from 2025 AHA Emergency Care Guidelines. Using ECMO and MCS for the general cardiogenic shock population. Again, this is the same one I just showed you, but in comparison and sort of equating it to cardiogenic shock for the sort of populations we've been talking about already, the post-MI population, use of ECMO and balloon pump is now a class 3 no benefit recommendation, again from 2025 from the ACS guidelines. And so just keep that in mind as compared to Impella, which are the microaxial intravascular flow pump, which bumped up after the danger shock trial. And so there is a difference now among the devices for post-MI shock between Impella use and ECMO and balloon pump in the guidelines. So in conclusion, cardiogenic shock has a mix of severity and etiology, and we have to think about all those things to phenotype our patients before we choose ECMO as well as any other hemodynamic support device. Protocolized escalation pathways are common, and that's the data that I showed you from the prospective work from Columbia. And that you might be able to have a escalation pathway that gets you to ECMO in some patients, but might spare some patients from ECMO if they improve with devices that provide less support. Randomized trials have been small in general, and really only 2 of them have been done for ECMO for cardiogenic shock without or outside the setting of ongoing refractory cardiac arrest. And so questions remain, and we definitely need more data. Guidelines have begun addressing these different uses and will likely evolve over time with more data and also with more experience. But remember that routine use is the big sticky point that a lot of the guidelines are refusing to, are using the routine and do not want you to use it routinely, but still in select patients. And then the question becomes, who is the selected patient? And that's where a lot of work needs to be done. That's the critical point. And then just the use of ECMO in refractory cardiac arrest and toxicological emergencies is growing in parallel, and I would argue faster with those trials being done. But especially for toxicological emergencies, a lot of it's sort of case series and experiential. So, you know, that evidence still matters, but we do need more trials in those settings as well. So that's what I have for you. Thank you so much for the time and for having me, and looking forward to the panel discussion.
Great. Thank you so much, Jason. That really was a perfect setup for the conversation, and you highlighted where we really have inadequate data, and so we have to make clinical decisions. And I think that's where really we can help the audience the most, and talking through how we make some of those decisions. We are very fortunate to have 2 additional experts in the field join us. Jason Gluck is the System Director for MCS and ECMO in the Hartford healthcare system. And Raghu Sathala is one of my colleagues at Mass General Brigham, and the Medical Director of ECMO at Brigham Women's Hospital. So thank you both for joining us. First, I'll encourage the audience, please, if you have questions, answer them into the Q&A. We'll try and monitor those and interweave them into the panel discussion. And if there's anything we don't get to, we'll make the effort to get back to you separately if there's a question that we didn't have time to address. So I think that I saw Dr. Kirchhoff's hand up briefly. If Mitch is my co-director for the co-chair for the Cardiogenic Shock Registry. And Mitch, why don't you go ahead with the first question to kick us off?
Yeah, thanks, David. Jason, first of all, I want to say thank you for such an incredible theoretical and practical overview of this emerging and still growing field. One of the things that I wanted to ask you to comment on, if you would, is the evaluation. As you said, by the time you guys get called for ECMO, for VA ECMO, it's usually doom or beyond. So in that setting, there's a significant presence of patients who have atherosclerotic disease in the large vessels. And I just wondered if you could walk us through, with a firefight going on to try and save a life that's failing, what is the approach to understanding, or what kind of imaging, arteriograms or other, or do you just go for it? How do you discern if a cannula isn't going well into first selected access, where you go from there?
Yeah, that's a great point. Because coronary disease is so prominent, peripheral vascular disease is too. And certainly, like you said, there's a lot of disease, a lot of places. I think in general, practically speaking, unless we have a concrete history of peripheral vascular disease, we're going to favor and use the ultrasound and lean on it quite heavily to look. Again, we're looking primarily femorally in the emergent setting and in the urgent setting. And so we're going to just use the ultrasound to scan for calcification. But the backup devices and tools are smaller cannulas and dilators. So as you, just to practically get into cannulation for a moment, you're going to get a classic Seldinger wire, a needle wire into the vessel, and then you're going to start dilating up. And there are a series of dilators that we use. And if we find resistance at the smaller dilator, we will either see if we can downsize our cannula to that, or if it's too small, we will just leave that in and go to an alternate site at that point. So to some extent, it's based on feel. There is the potential that a proximal iliac lesion could prevent and could not be detectable in that sort of way and description. So it is incredibly rare in our institutional experience, at least, that we would have to do this, but we have on rare occasion put an entire cannula in, found out that our flows are so limited by a proximal lesion, and then we will put another cannula in the other side and use the other groin and hope that it's better. But you can push a cannula through a lot of calcium, and as long as there's a lumen big enough on the other end of that cannula, you can get a fair amount of flow, at least 2 or 3 liters, to start stabilizing the situation and then troubleshoot from there. The backup of all backups, if you have the option, is central ECMO. So if everything else fails, all your sites fail, central ECMO is the backup option. You need a surgeon that would be interested and willing to do that in a given patient's case. But it can be a challenge.
Okay, so I want to take it up to 30,000 feet and talk about the critical question that you introduced, Jason, that is selection. And maybe I'll go to Dr. Gluck and have him speak to this first. Just at a very practical level, with all the tools that you described in that armamentarium, how do you make a decision that this is someone where I've gone beyond the routine, right? And I need to escalate as opposed to selecting a patient, for example, for CP. And even if you thought they needed biventricular support, using biventricular support that's microaxial other than ECMO.
Yeah, thank you. And I'll echo Jason, good first name, great presentation. So thank you. Thanks, David. That's everything. I think one thing that I always say is shock is not shock is not shock. Cardiac arrest is not cardiac arrest is not cardiac arrest. And ECMO is not ECMO is not ECMO. There's so many details to all these things that come into play. I think the first thing that I always think about is neuroprognostication and doing the best I can there. And there are two. I like to try to take the doctor out of it and kind of come up with scores or ways that we can really do that. And Harsha really published a beautiful schema in cardiac arrest on neuroprognostication. It's very simple, easy to remember, easy to put in the pocket, and kind of breaks down into likely to have a favorable neurologic survival over or under 40%. So I'm happy to share that in the link or something. But I think that's a great tool when it comes to neuroprognostication. There's also the CAP score, which is also helpful, but using these to try and neuroprognosticate. The second thing is in the event of what's going on, try and leverage the data you have at hand. So a cardiac arrest with an end-tidal CO2 of 25 is much different than a cardiac arrest with an end-tidal CO2 of 5. And so at least in our practice, we leverage end-tidal CO2 in real crisis as a measure of cardiac output and of effective resuscitation. If the end-tidal CO2 has been 5 for 20 minutes, that person's a lot less likely to do better than if someone's end-tidal CO2 has been 25 during resuscitation. So we've used that as a tool as well. The last thing that we use is lactate and pH. And with point of care testing, that can be good objective data to help us figure out from a physiologic perspective, where is that person? A lactate that's over 7 versus under 7, that seems to be the evidence-based magic number. If you're over 7, it's a much bigger reach than if you're under 7. And if the pH is under 7, same, or versus over 7, I think also makes a bigger reach unless it's really purely hypercarbic respiratory failure. So these are some of the tools at the bedside that we use to try and take the gut work out of it and try and put some objectivity to it, because all of us think we could save everybody. But we have to use some data to try and bring some reality. The last thing that I'll say, if I may, sorry, David, is we have a two provider system. So in our institution, you have to have 2 docs from 2 different specialties that agree this is an appropriate patient. And when we're gloved up and we're in the middle of a case, all of us want to save that patient. But having an outside perspective that takes 60 seconds to get is a very valuable 60 seconds. And I think we've had that save us sometimes from putting people on and actually convince us to put somebody on when we might otherwise not. So that's the last thing that I would say. Thanks.
Yeah, no, thank you very much for that. That's really helpful. It's a perfect segue into another area for us to talk about. Some of the questions that have been submitted in the Q&A are asking about what infrastructure do you need to have an ECMO program that can be successful? And maybe I'll turn to you, Raghu, and if you could talk a little bit about just what do you need for case volume? What kind of setup do you need, as Jason was just saying, in terms of a team, multidisciplinary team? And are there other sort of absolute elements that you have to have in your system if you're contemplating starting an ECMO program?
Thank you for that question. Having been instrumental in developing our program at our institution, I think you were very familiar with a lot of the things that we've done here. But I think the way I think about ECMO in the treatment of cardiogenic shock is that it's just one tool, and you really have to have a comprehensive cardiogenic shock program or a shock team to take care of these patients. So, I think everything that you need to have a successful ECMO program, for caring for the cardiogenic shock program goes with the whole spectrum of caring for cardiogenic shock. So you need to have a multidisciplinary team that takes care of these patients, and starting all the way from EMS all the way to the ICU and every step all the way between there, and even stepping down from the ICU. You have to have the nurses and buy in the emergency department, interventional cardiology, anesthesia, cardiac surgery, and have a champion in each of these disciplines that are really going to fight for these patients, because these patients take a village to care for, and you don't want to, put a patient on and then in 2 days later, everybody says, nope, this patient's not going to make it after all the time and effort that you've invested into taking care of these patients. So I think getting institutional buy-in from all the key stakeholders, and not forgetting about stakeholders that you may not think about. I can see the cardiac surgeon not really thinking that, I need to get the director of EMS on board, and, vice versa. But understanding that every single step, it's kind of like the chain of survival that AHA has for out-of-hospital cardiac arrest. You want to make sure that every key and chain and link has a champion, and that the whole institution is bought into this, because these patients will stay for some time, and you really need to be able to allow them to neuroprognosticate and get all the downstream care that they need.
Yeah, no, I think both you and Jason emphasize this, and Gluck emphasize this very well, that you really do benefit from having a team system, especially in the decision making. I think that two physician model, and as Raghu was describing at the Brigham, we actually bring in heart failure, critical care, and our ECMO leads all to have a conversation at the same time. I want to touch on a few other areas, just a little bit more rapid fire to answer questions that people are thinking. Maybe Dr. Gluck, next. First, do you have in your mind a minimum number of case volume per year to kind of keep a center that's adequately experienced?
Yeah, at our Hartford Healthcare, we do about 75 to 100 cases of all comers a year, and about 20 to 30 of those are ECPR.
Yeah, no, that's super helpful. And then Jason Bartos, I know your orientation to this, but how do you decide? Is it bedside cannulation, cath lab cannulation, where you cannulate for a patient in the hospital?
Yeah, I'm biased because I'm also an interventional cardiologist. So I think that for me, the cath lab is the optimal place for cannulation, but it doesn't necessarily mean that getting the patient there and the timing of that is going to be optimal. So sometimes you step to your second best option because for that patient, it is the best option. And that can be bedside in the ICU or in the emergency department. If you're going to be cannulating a lot of ECPR patients with ongoing CPR where risks are very high and time is very low, I would just plan it out and have a C-arm or other tools that you can bring to that location. But if you are cannulating cardiogenic shock and you have time to work, then I would say getting them to a controlled environment is probably reasonable in the vast majority of cases. So that's sort of how I would think about it.
Yeah, no, that's helpful. Raghu, feel free to add to that. And then I also want you to speak to BMI. Do you draw the line? Is there a hard line anywhere? How tightly correlated with safety and outcomes?
I think BMI is kind of an outdated, relative or absolute contraindication. I think with the advent of using ultrasound, it's more can you cannulate or not? And knowing that in VA ECMO, there may be a little bit more complications or mortality associated with elevated BMI, but from my standpoint, it's really, can you get the cannulas in? And that's going to really be based on, using ultrasound and other things rather than just the BMI.
Yeah. Back to Dr. Gluck, venting or not? Do you routinely vent? When do you decide about venting? How do you make that decision?
Yeah, thanks for the easy one. I think for eCPR, I most of the time we're bedside cannulating with ultrasound, and that's about it. And then we make a decision on the backside. I would submit if you're doing straight up VA ECMO for a cardiac reason, most are being either unloaded or vented mechanically, either with an Impella or a balloon pump most of the time. If you have great pulsatility and there's good pulsatile flow across the aortic valve in those patients, I may not do it. If there's no pulmonary edema, I may not do it. But I think I would say 80 to 90% of our VA ECMO patients for cardiac reasons are getting a mechanical vent or unloading of some sort.
Yeah, I think that's another area where we really need additional data to help guide us, but we're doing the same. I think we're venting a very high proportion, but it's not always needed, is the summary there. Maybe I'll go back to Raghu for a second. We do have a mobile ECMO program. How do you decide whether to just go ahead and have them ship and get them to the mothership here versus a decision to try and cannulate at the referring hospital?
I think that's a really great question, and I may actually pass to Jason because he actually
Yes,
came over here to train us before we start. We actually did our first mobile ECMO, I think 2 weeks after he had given us the mobile ECMO training and course. So, Jason, you want to take it? Jason Gluck?
Yeah, thanks, Fred. It was a pleasure to work with you on that. So we've been doing mobile ECMO now for 15 years. I think there's a couple things. Number one is developing a very good relationship with your EMS folks. The question is, do they feel they can safely move that patient or not? If they feel they can safely move the patient, it's always our preference to move them to us. But if they're maxed on 2 or more pressors and they're still hypotensive, if they're refractory acidotic, or if they're on a machine and maxed on 1 or more pressors where they don't have a whole lot of room to move, those are the people that we tend to go out and cannulate on the go, as opposed to letting them move them. We really want EMS to have a little bit of wiggle room when they move a patient, because we all know once you move a patient from the hospital stretcher to the EMS stretcher, just that 1 foot of motion can cause significant hemodynamic duress. So if EMS really is maxed and they don't have out obstacles, at least in our system, they've become so trained now, they just say, I'm not moving you. You stay where you are. I'm calling the ECMO team, and they'll actually activate us. So I think a good relationship with EMS and a good relationship with your referrings. And we actually have a guideline that we post and we send out to everybody. If this for VA and this for VV, then think about mobile ECMO prior to movement. And our team, actually at our shock symposium, they just gave a talk. It used to be there's nobody too sick to move. And we've changed that culture in our EMS, whereby, there are people that they know movement is not the right thing necessarily, and will cannulate first and move second.
Yeah, well, that's a really good lesson. It also just speaks to the value of that multidisciplinary approach and speaking to each other within the system. Raghu, then I will come back to you because this is an area we've been thinking about. For one of the questions in the chat is beta blocker and calcium channel blocker toxicity, and when for those patients is ECMO appropriate? Another easy question.
Yeah, no, that's a great question. I think it's a complicated question because the physiology could be predominantly cardiogenic shock or predominantly vasoplegia. And there's, an older thinking that ECMO doesn't help for vasoplegia. But I think, from my standpoint, if the patient's in a high cardiac output state, I'm not entirely sure that ECMO is going to be beneficial. But at some point, these patients that are profoundly vasoplegic, won't be able to keep up. Their heart won't be able to keep up, and you really have to pay close attention to. And it may not just be the echo, because if you have wide open, profound vasoplegia, a normal EF on your bedside echo may actually be a significantly reduced EF. It's just that they have no afterload to pump against. So I think it's a tough question, but I think maybe starting to think about using some vasopressor inotropic score versus signs of actual decreased cardiac output may be helpful. Your mixed venous is down a little bit. But I think just looking at the echo and saying that the heart's got good squeeze is probably not enough to say that the patient doesn't need ECMO. I'd be interested to hear the other
Yeah, can
panelists
I
as
add to
well.
that, Dave? Is that okay?
Yeah, please.
One thing is I recommend to everybody, I can't overestimate the use of hemodynamics. And so now, especially point of care echo, anywhere you can do an LVOT VTI, or you can get a central venous sat. I would encourage everybody when they're thinking about these things, do some sort of measure of cardiac output. And that'll help in these. We've seen these cases skyrocket. And often, when I'm of the same opinion, Raghu is, if there's hyperdynamic cardiac function, I'm not sure stealing preload is the right answer. But understanding that cardiac output is going to be very important to clinical decision making. So if you can help us with that on the referral, that would be amazing.
Yeah, no, I think that's absolutely true. And also, at least we really believe it's very important to deciding on your MCS strategy in the first place, is really either non-invasive or invasive hemodynamic estimates and getting a good sense of what the right ventricle is doing. All right, we have just 3 minutes left, and been a fantastic conversation. I'm going to go around the horn with each person with just a hi, but maybe challenging questions. If there's sort of one bit of advice you would give to everyone in formulating their ECMO program, what would it be? Maybe I'll go to Dr. Bartos first as our lead. What's the key piece of advice you give to folks?
It's not something to rush into quickly and without preparation. And I think that point about having the whole system built before you start from pre-hospital all the way through clinic is really critical. You have to be involved in all that and leave the hospital walls to get all that set up before you dive in. Otherwise, it doesn't take too many disasters to demoralize your team, and then you can't move forward. So.
Yeah, you definitely have to celebrate the wins because you always remember the losses. That's for sure. Dr. Glock?
There we go. Okay. Sometimes the least common thing in medicine is common sense. So I think don't forget to zoom out for a minute and look at the big picture. I think sometimes we're so focused on what we can fix that we look at each organ system as a system and how we can fix it, but we don't look at the organism. And I think that remembering the big picture is really crucial, because ECMO has a ton of sex appeal, but it can't fix everybody.
Yeah, no, that's great advice. And I'd say we talk about this all the time when we talk about our indications and contraindications. It's all relative. And as you just said, you really have to zoom out and zoom in. Dr. Sivala?
Yeah, and the last thing I'd like to, just say about ECMO or MCS in general is that I think we're really moving away towards absolute contraindications and moving towards kind of thoughtful, thinking about the patient in front of us and relative contraindications, and not being so dogmatic. Their BMI is 39.1, so they're no longer a candidate, but focusing more on the patient in front of us and thinking about how MCS or shock treatment can help them.
Yeah, perfect. Thank you very much. And so I'm going to turn things back over to Shayna to close in just 30 seconds. I say there was one other question in the chat, which I think is really important, which is just how do you bring everyone together into a shock team? And I'd say that one is, for example, you need a way to activate everyone at the same time. We use a group page system, and we have all the different individual systems that we just talked about, right? The critical care, ECMO, our cardiac intensivists, our surgeons, and our advanced heart failure folks, and they all join at once. And education really is key in getting to everyone for shock recognition. So with that, I'm going to thank all our speakers, our panelists. That was absolutely fantastic, and turn it back over to Shana Costello to close.
Thanks so much, Dr. Morrow, and thank you. I just want to echo again to all of the speakers today. It's just fantastic, and we learned so much from you and appreciate your time. To everyone in attendance, if you do have questions about the cardiogenic shock registry or any follow-up questions for our speaker, please just feel free to email us, reach out here. And as a reminder, this recording will be shared with all of you and also available on our website. Thank you all so much, and take care.